I've asked Victoria, and I'm just making that assumption, please forgive me if I'm wrong, that perhaps not everybody's familiar with the concept of value-based healthcare, and I've asked her just to give us a short précis on the notion of value-based healthcare and how it's different from what does the paradigm, what about the paradigm is different from what we currently do. Thanks.
Sure. Thanks, Elton. So value-based healthcare is an approach to healthcare that focuses on both cost and outcomes, and basically seeks to maximize outcomes for patients, the best outcomes for patients, and to minimize cost. I mean, the area that I work on is really very much around how you pay for and contract for healthcare in order to incentivize providers to focus on both of those things, so to have a joint focus on both cost and outcomes. And so the predominant model of payment in the South African private healthcare system is, as you'll I'm sure be aware, the fee-for-service model, where all of the costs of a patient episode in hospital, for example, are passed on to either the patient or their medical scheme. So every single line item of the bill is passed on. And this obviously doesn't give the provider any incentive to provide care in an efficient way. So from a value-based perspective, that's not, there's no incentive in the payment mechanism to focus on the cost bit of that, of the dual focus. We might come on to talk about the DRG model, which is used, for example, in the UK to pay for hospital care. So it's a sort of fixed fee for a particular episode of patient care, and that would have more of an incentive for efficiency because the individual components of the episode in hospital are not all individually passed on. So there is an incentive for the provider to focus on efficiency. But there isn't, in that model, either any particular focus on quality or outcomes. So that's really, I hope that's a quick intro.
So does that mean that outcomes are poor because of that, for instance, or?
No, I mean, if you think about the South African system and you think about fee-for-service, there is, a doctor wants to be 100% sure, so he runs 12 tests. Actually, what added value did the 9 additional ones add? He could have got the same results from running 3, but obviously he wants to do the best for that individual patient in front of him, so he runs 12 just to be sure. Now, from a system perspective and from a taxpayer or a medical scheme member perspective, would you want your providers of care to be thinking about efficiency? And as a payer, yes, you would. Obviously, as an individual patient in that moment, you might have a different answer. But I think the issue around value is that dual focus. It's it's about striking the balance between the cost and the outcomes. And the issue is that the people who are best placed to do that are the people providing care. So it's the doctors, it's the hospitals, it's the people who are actually making the decisions.
Okay. No, thanks. Shrey,
yes.
Can you tell me, in terms of our maturity, is this a good model in your mind? And where are we in the implementation of it?
I think it's a phenomenal model. I think the system's not set up for it today. And you forget even the previous panel around where we're moving. I think the current private sector model is, in my mind, flawed for an outcomes-based model. I think you've got, let me call it what it is. Everybody cares about the patient. Let's start there. So I don't want to make it sound like no one does. The hospital groups absolutely do, but we for-profit entities. The doctors absolutely do. And I disagree with the suggestion that doctors over-investigate unnecessarily. I think clinicians, 3 of us who are sitting here, are always mindful of the cost of it. They're trying to do the best they can in the model that works, but they're also for-profit entities, right? They're not NGOs. As are the funders, which was consciously excluded from that bit. The funders exist. They absolutely care about their patients, but they're also for-profit entities. You've got 3 competing institutions trying to work in an integrated way, all of whom have a competing profit motive. which at the end of the day is going to misalign to best outcomes for a patient. If you look at the models that work, where outcomes are working, probably best examples of the US, they're all integrated health systems. The doctors, the funders, the providers are in a closed system also, which means you can control how much is pushed down into a primary care environment versus secondary versus tertiary, which avoids all of the health economic effects of perverseness.
Okay. So why would that not be happy? I mean, if it's a better model, it suits everybody, suits the patient, suits the funder. What are the barriers in the South African setting in your mind?
I'd go back to you've got misaligned incentives when everybody's existing as profit-making entities, right? I think part of, not to drag us back to the previous panel, but part of getting to universal healthcare models is suddenly a funder focus is about clinical outcomes and quality only at a population health level as opposed to a profit motive,
Okay,
right?
good. Jasper, if I can ask you, did I pronounce your name correctly? And I gave you the Afrikaans pronunciation of Jasper. Is that
that
okay?
works
Good.
also. That works also.
What do you see the role of technology companies like yourself in the value-based care movement?
Good morning. Maybe first to start, I think there are a couple of elements that we did not mention yet about value-based care, because it's also about the healthcare providers. You think about the stress they're under, the workload they're under. So we always look at it from 4 angles. Of course, we look at lower cost, but we also want better outcomes, and we want the patient and the healthcare provider to also get a benefit. And you can make this a very intricate, elaborate scheme, but you can also just bring it back to very basics. Because in principle, what you try to do is you try to standardize, you try to measure, and you try to optimize. And actually, you can do that in any setting. So we as a company can help with large-scale projects to make really large-scale transformations into healthcare where you change the way business is done. But you can also start at your own practice or at a smaller level where you simply start, hey, how do I standardize a procedure? How do I now measure the outcomes of the procedure? And how do I optimize? And it's a little bit that circle that needs to come. Because the way we look as Philips at value-based care is really that it's a continuous refining of what you're doing to drive not only the best cost, not only the best outcome, but also to get a happy patient, a satisfied patient, and a satisfied health professional.
Fantastic. Unati, so I'm going to, in your position now, and let's forget about, as we say, let's leave the previous panel behind now, okay? It's the status quo, nothing's changed. As the minister says, probably Anban Pillay says, you know, this issue of what medical aids will be providing or not is quite open, and that's my reading of it anyway. What's the role of schemes in putting these models together, and is there examples that you can share with us around that? And what do you see as the challenges?
So I think before maybe speaking about the role of a funder, so I'm speaking from the funder perspective, I'd like to maybe contextualize the business case, you know, for value-based care. So in our context, I think, I mean, my fellow panelists here have mentioned some of the challenges with the prevailing fee-for-service environment. So the issues for us as a funder is sustainability. And sustainability as it is very much threatened at this point in time. And the reasons for that, I mean, is multifactorial. There's the issue, number one, of, escalating healthcare costs related to increased utilization, both from the supply side and the demand side. You know, we have, I think even the minister, referenced the issue of the burden of disease, especially in, the chronic conditions, and also other issues like oncology and so forth. There's also the issue of, new health technologies, innovation, but that comes at a very high cost. So, within that context, as funders, you are finding it very difficult, to keep premiums, affordable for members. And again, that's in the context of the macroeconomic environment where there's serious affordability constraints, for members, or even those that are outside of schemes at the moment to actually enter the medical insurance environment. So that is the context within which we are, we are operating. And then we talk about the issue now of how do we then, ensure that we remain sustainable, going forward. So Victoria has, I think, elaborated enough in terms of what is wrong, or what are the cons of a fee-for-service environment. So in terms of our role as funders, therefore, we want to actually embrace the concept of value-based care, because ultimately, in any system, whether it's, a medical scheme environment, whether it's an NHI or any other universal healthcare system, you want to ensure that the resources that are the inputs into the healthcare system, that are used for delivery of services, actually, improve the outcomes, the outcomes of the consumers, and ultimately the population that is served, within that context. So, in our coming, to our my organization specifically, Discovery Health Medical Scheme. And here I have to acknowledge, the administrator that, is our partner in this journey. We have actually championed, we've been on a journey where we've, instigated and actually championed within the system value-based healthcare models. It's a journey. It's difficult. There are challenges. So, when we talk about barriers, there's significant barriers in terms of how you can do it, but I think we cannot, be deterred. We have to persist. A lot of it requires, engagement. I think there's been a lot said today about stakeholder engagement, collaboration, co-creation, trust issues, building that trust, but ultimately it has to be about the alignment of incentive of all the role players. And the role players within value-based healthcare is, yes, the patient, the consumer is right at the center of it. Then you've got your providers, then you've got, and you need to bring in the regulators also, because part of the challenge in our current environment is we've got regulatory constraints where, we've got, for example, a regulator that's not necessarily, supportive of newer models, alternative reimbursement models like global fees. So we need a regulator that is moving in the same direction.
Which the Council for Medical Schemes or the Health Professions Council?
Yes, the latter. Okay, so we need support in that.
Just clarifying.
But also we have regulations, for example, like the single exit price, regulations, which make it difficult, to contract, on the basis of outcomes, on the basis of value, because you are stuck to the single exit price, framework, for example. So there's a lot of barriers, but maybe I just want to, speaking as a funder, maybe to just say, in the context of what Shrey has said are some of the barriers, the profit motive, just to clarify for the audience that funders in the South African medical context, the funders being medical aid schemes, are not for profit.
Yeah, the administrators.
So we don't have a profit motive
let's hide behind
at
the
all.
nuances of that.
Yeah, but they're for reserves, which may be the same thing.
But then again, we talk about the regulator.
For reserving.
Sorry.
So it's not for shareholder profit, not for
I
shareholder.
apologize. I meant
not
the
for shareholder
administrators.
distribution.
I sincerely apologize.
No, but that doesn't mean schemes are not focused on getting services at less than their total.